Well, welcome everyone to the cardiology marathon part of med study, but I promise you I will try to keep it as interesting as possible. So just a little bit about myself. Tony mentioned, I believe in the words of Gandhi, be the change you want to see in the world. So I'm a runner. I like to run. I've completed 13 marathons as well as the 10 by 10 challenge, which is running 10 miles every day for 10 consecutive days for 100 miles. And I challenge you all to set yourself a goal not only for passing the boards or whatever that may be, but also a physical goal, because it's important for your health, both mental and physical, to be at its optimal so you can perform best for yourselves, for your family, for your patients, etc. Okay, so we're going to be doing 5 segments today of cardiology, and each segment is going to be about 55 minutes. I'm going to try to give you a little bit of a 5-minute break after each lecture. So what was my board prep that I did? You can see I passed both the maintenance of certification in internal medicine and the cardiology med study. And to quote from the Matrix, Neo, sooner or later you're going to realize, just as I did, there's a difference between knowing the path and walking the path. Well, I have walked the path, just like you, many of you are walking the path. And my presentation does follow the template for the boards. So first of all, let me introduce myself. Who am I? Who am I? I am Dr. Star-Lord today, and you all are the guardians of the medical galaxy. And I have a plan. I have part of a plan. Our nemesis, the board exam. And as I mentioned, my content will directly reflect the ABIM contact. And I met someone in the elevator this morning, and they asked me this, and I will tell you all. First of all, due to traveling at turbo speed, we will not have time for questions during the presentation, but if you want to grab me during the breaks, that's okay. And to quote Rita, I will never let you down. And if you've enjoyed my presentation, I would be honored to receive a sweet feedback score. Okay, so let's start lecture 1. So here is what we're going to cover in this lecture. A little bit of imaging, x-rays, echo, some of the more advanced imaging, and then a little bit of physical exam at the end of the presentation. So firstly, chest x-rays. It's important. Chest x-rays are still an important part of internal medicine and cardiology. And hopefully you would recognize someone with this chest pain and a wide aortic knob here who is having an acute dissection, and someone who will live to see the morning, unlike our couple in this famous opera. So important, first of all, is what is normal in a chest x-ray. So you should be checking the chest x-ray and make sure you see certain things on the chest x-ray. For example, you want to make sure you see an aortic knob. If you don't see an aortic knob and you were to see notching, rib notching, you might be thinking, coarctation. You want to look at the size of the heart, the left atrium. Is it big, left ventricle, etc.? So it's important just to have an idea of what's normal. So let's take a look at a couple of abnormal chest x-rays. This is a 75-year-old male who presented with dyspnea and pedal edema, worse for the past 2 weeks. So take a look at his x-ray. Hopefully you can see some of those abnormalities. Let's take a look. This is a patient with severe heart failure, and you can see there the enlarged left ventricle with the cardiomegaly, the nice plump, juicy pulmonary vessels, and the pulmonary vascular redistribution. You can see large vessels toward the tops of the lungs, which you normally should not see. And then if you squint your eyes, you can see the curly B lines and a little pleural effusion there. This case is a 22-year-old end-stage renal disease male who had dyspnea over the past 2 months and missed multiple dialysis sessions. Came in really dyspneic, hypotense, and this is his x-ray. So this has something, the diagnosis or the kind of term for this has something to do with back in the day when we used to travel around via camel. We used to have to carry these with us for these long journeys. And so this is water bottle heart. And so this teaches you that not all enlarged cardio silhouettes are from heart failure. And especially if you have enlargement of the silhouette completely around the heart. So you can see the this on this side here, the right side and the left side. So this is an effusion on both. It's something surrounding the entire heart. And if you can squint your eyes, you can probably see where there is effusion and where there is heart there. And this is a classic pericardial effusion. This is a 45-year-old female with lymphoma, status post-mediastinal radiation. Comes in with peripheral edema, ascites, and hepatomegaly. And so remember, not only you're looking for things that might be missing on the x-ray or different, but you're looking for things that normally you shouldn't see. And hopefully you can see on the x-ray something that you don't normally see. And that something is calcification in the pericardium there. And this calcification you can see also on the CT scan, and this makes the diagnosis of constrictive pericarditis, aka skull heart. Okay, time for your first question. A 19-year-old male patient presents with high blood pressure. He's got a history of bicuspid aortic valve, and he's on metoprolol for the hypertension and hydrochlorothiazide. So his blood pressure, 200/90 in both upper extremities, and he's got an ejection click and a systolic murmur at the left sternal border. Also, another different systolic murmur is heard under the left clavicle. The radiofemoral artery pulse is delayed. No abdominal bruits are heard. And lab is normal. Here is the chest x-ray. So I want you to take a look at that chest x-ray. And, if you can also look in your books too, you might be able to, and take a look at that. Hypertension, what do you think might be going on in this case? And a little bit of a hint, something that we normally see on the silhouette we don't see in this case. So what is the likely cause of the hypertension? Essential hypertension, coarctation of the aorta, renovascular hypertension, or tetralogy of Fallot. I hear your clickers clicking away. Wow, 94% at 8 a.m. in the morning, fantastic. So hopefully most of you, essential hypertension is kind of pretty unusual, rare in a 19-year-old. And tetralogy of Fallot, he does not have a boot-shaped heart, but he does have signs of coarctation of the aorta. And first one is he had a bicuspid aortic valve, because 70% of people with coarctation have a bicuspid aortic valve. He had high blood pressure. He also had, and I've got his x-ray up there for you, he doesn't have an aortic knob there. You normally should see a nice little juicy aortic knob, and the reason he doesn't have it is because it's not there. And it's not there because instead he's got a narrowing or coarctation there. And secondly, he has the rib notching. You can see, hopefully, if you look under those ribs, you can see those little bumps. And that is caused because you have problem with blood flow from going through the usual aorta to the lower part of the body. The body says, hey, let's use some other arteries because we need to get that blood still from the top down. And so it uses some arteries off the branch of the aorta before the coarctation. And some of these artery branches go down in front and behind the ribs. And so from birth, those arteries are carrying more blood, they're bigger, more juicier, and they actually cause the indentation as the ribs grow. Also, you can sometimes see a pre and a post dilatation on the arch. So for example, here we call it the figure 3 sign. Remember to check the brain out because coarced patients, birds of a feather flock together. They have the bicuspid aortic valve. They also can have baryaneurysms in the brain. So take a look out for that. If you have a Turner syndrome, always think about your coarced and bicuspid. And then finally, when to do surgery or to stent them. We can stent them these days. If their peak-to-peak gradient is over 20, if they have hypertension or heart failure. So this individual would be referred to get this coarctation fixed. Let's now move on to our bread and butter transthoracic echocardiography that we do, echoes that we do pretty much on a daily basis. So what are the indications for transthoracic echocardiography? Cardiac structure and function, pretty straightforward. Arrhythmias, high blood pressure, as well as in the acute setting if they are hemodynamically unstable. Valvular function. If someone has a murmur, for example, that's a loud murmur and it's late, it's not a innocent sounding murmur, we want to make sure we get on top of that. Maybe they've had an embolus and we're looking in the heart to see is there any cardiac source of embolus. Aortic disease, so someone with Marfan's, if we are suspecting that they might have Marfan's and we want to take a look at the heart, look at that aorta in particular. Hypertension, heart failure, or cardiomyopathy. And then finally, someone with a fixed split S2 that you are hearing and you're thinking, maybe they have an ASD and we want to take a look with their echo. And here is such a patient that you can see here with an ASD there. Here is someone with a VSD who had a hemodynamically unstable as examples. Now, just as important of knowing when you should do the transthoracic is when you should not do it. What I call the just don't do it, the anti-Nike. And I like has anyone read Born to Run, the book, or listened to that? Got a couple of hands there, awesome. It's a great book on, sort of tells the history a little bit of the running, and also there's a guy in there called Barefoot Ted who is anti-shoes, and he started the whole barefoot kind of movement, and he's very anti-Nike. So anyway, who should you not order an echo on? Well, let's say you have someone who has a classic innocent sounding murmur that comes into your office, especially if they're younger and healthier. So a 1 to 2/6, well localized, systolic mid-peaking at the left sternal border. I mean, that's a classic RVOT or PA flow murmur, particularly in a younger person that is thin. Or in a lady that is lactating and you can hear a venous hum over the breast. That's a mammary souffle. So you don't want to, get an echo on them. And you don't want to get an echo every time you are seeing your heart failure patient in your office. However, if there is a clinical change, so if someone comes into the hospital and is admitted with acute decompensated heart failure, absolutely get that echo, because there might be something new going on that is contributing to that decompensation. And then finally, valvular disease. This is the one that the boards like to ask a lot about. And, in terms of should you just follow them clinically next year, or should you follow them clinically and get an echo? The main thing to know is for mild valvular disease, so your mild mitral regurg or your mild aortic stenosis, you don't have to do an echo annually. In fact, the guidelines say every 3 years, or if there is a significant clinical change. So your physical is okay. If you have moderate or severe, it's okay, and very reasonable to do an annual echo to check for changes, because at some point they will or may need to go to surgery. Okay, let's now move on to transesophageal echocardiography. So this is, the main things to remember about this is it's better resolution. So regular echocardiograms are about 3 millimeters, 4 millimeters resolution. Transesophageal is 1 to 2 millimeters resolution. So in other words, we can see smaller things, tricky things to see better. So what are the main indications? Well, if you want to see cardiac structure or aortic structure and function, and you're not getting good images with the regular transthoracic echo, or if you're suspecting maybe someone with endocarditis, and it's endocarditis, and then all of a sudden they develop a complete heart block or a first-degree heart block, and you're thinking, maybe they've developed an abscess, and the infection's not getting better. So you can do a transesophageal echocardiogram, and hopefully you can see on this image here. Here's a transesophageal echocardiogram. Here's an aortic valve vegetation. Here is an abscess here, up here outside the aortic valve. Also, intraoperatively these days, we're pretty much doing a lot of, anesthesia does a lot of transesophageal echo on pretty much most of the cardiac cases. It can really help them to manage the cases and to get better outcomes. Transcatheter in particular, especially transcatheter. So TAVRs now, MitraClip, etc. And then finally, you might have a patient who is critically ill and they might have been in an accident, they're on the ventilator and you can't get good images, they might have bandages, etc. And you want to get some information about the heart because it's really important to make decisions for them. That's when a transesophageal echocardiogram in the unit, for example, is a great idea. And here is just an example of a mid-esophageal view, just to show, so you can see the esophagus here in yellow and the aorta and the heart. So this is where the probe goes down into the stomach. We start with transgastric views and then we pull the probe up, lower, mid, and then upper esophageal views. And here's an example of a mid-esophageal view showing the left atrium, right ventricle, and left ventricle, and the anterior septal on the right side of the tricuspid valve, and then anterior and posterior on the mitral valve there. Let's now talk about stress tests. And it's important not to stress out about cardiac stress tests. They are best if you have intermediate probability. So for the person that has the family history, has the exertional angina, classic story, has the risk factors and all of that, and it's gotten worse, and now it's happening, with minimal exertional rest, that's a slam dunk, cath lab. On the other hand, if you have a person that tells you that they work out, they never get exercise on exertion, but they always get it when they drink down their ice-cold soda or their ice-cold water, afterwards, and that's when they get the pain. But never with exertion, then you'll be thinking of something else, like diffuse esophageal spasm, for example. So we're okay with those groups, but the intermediate group is a big chunk of patients. And so who are those people? Well, if you've got someone who's younger that doesn't have a lot in the way of risk factors, but the story sounds pretty good and you're kind of concerned, or if you've got an older person that has atypical pain. And remember that women, the stress tests are lower sensitivity and specificity. So we normally start off with the exercise treadmill test, no imaging, also known as exercise electrocardiography. And that will give us a good indication if if their chest pain is related to ischemia. It's pretty good. Sensitivity about 65%, specificity 75%. So in other words, if you've got a chest pain patient and they have a pretty normal ECG to begin with, and they can exercise, this is a pretty good test to start with. They have to be able to achieve a reasonable degree, 85% maximum predicted heart rate. So let's take a look at some other high-risk findings that you should be aware of on the exercise treadmill test. If they can't exercise very long, less than 4 minutes, for example, if they have a really low peak systolic blood pressure, if they get angina during the test, or if they have significant ST depression, especially if it happens early at a low rate pressure product. Early onset as well, if it happens in stage 1. If they have ST elevation, and then finally if they get bad ventricular arrhythmias like couplets or runs, that also is an indication of ischemia. And then if their heart rate doesn't come back to normal fairly quickly, that's also badness. So let's take a look at a person who came in, ruled out, and they can exercise, a younger person with not much in the way of risk factors, but a good story. So here is their baseline ECG, and we put them on the treadmill, and we were looking for change. Positive test, at least 1 millimeter of downsloping ST depression in 2 contiguous leads. And hopefully you can see on that ECG, lots of changes going on. So let's take a question. A 53-year-old woman presents to the emergency department with burning substernal chest pain without clear precipitating factors. So some history of smoking, hypertension, and is on lisinopril. You rule her out and the EKG remains normal. So you order an exercise treadmill test and she exercises for only 3 minutes, not long, and only gets a heart rate up to 110 and has her typical pain. So here are her ECGs. Here's her resting ECG, and there is her peak exercise ECG. Okay, so my question is, what should we do next to this lady? So early onset, something going on in the ECG, chest pain, what would you like to do next for her? Would you like to reassure the patient and say everything's cool? Repeat with nuke. Just put her on some secondary prevention or coronary angiography. And the clickers are off. Wow, awesome. So she had a very positive stress test, as you can see if you review later. Early onset, reproduced her pain, significant ECG changes at a low heart rate and blood pressure. The next step for her, this is a flunk, an absolute flunk. The next step for her is to go to coronary angiography. Some of you chose the nuclear perfusion. There's no need to do that. I mean, if you have a clear positive stress test like this, you know it's there. The nuke is going to be positive, and just in case you didn't know, the nuclear test runs about $3,000 to $5,000. Cardiac catheterization, coronary angiography, it runs about $1,500 to $3,000. So you don't want to be giving added expense. So you don't need that in this case. It's a clear answer. And then finally, the secondary prevention, she's already on good blood pressure control, etc. She's having this chest pain with minimal exertion. This is someone you can't sit on. You need to get them to the cath lab. So what about cardiac stress tests and imaging? So this is the next level. As I told you, the exercise treadmill is where we like to start, but in some people, we have to do some imaging modality. And we have a couple of options for that imaging. We can do nuclear or we can do echo. So who should we send for a stress test with imaging? Well, first of all, if they cannot get on the treadmill. So we can't do a routine exercise treadmill test. There are some people that can't. Might be that they have a walker or they have amputations or that they tell you that they just are unsteady. They can't do it. So that's number one. And secondly, there are certain abnormalities on the ECG that preclude us from doing a regular exercise treadmill. In other words, the exercise treadmill test will no longer work if they have, and there are 4 classic ECG abnormalities that will fall into this category. That if you see a patient with this, you got to say to yourself, that's a classic abnormal ECG. I can't order an exercise treadmill. I need to go to imaging. So let's go over those really quickly. So which side am I standing on here of your side? Left. Okay, first one, left bundle branch block is the first one, which you can see there. Okay, and let me give you, see if we can get the next one. Okay, what am I doing now? Oh, gee, can't believe those people at the airport, I mean, they were just like, pacing, yes, pacing. So paced rhythm is the next one. And hopefully you will notice on these ECGs that their ST segments often are kind of messed up. And that's part of the reason why the regular plain old routine exercise treadmill test is not going to work. Okay, so that is paced rhythm. Now, what am I? Okay, I'll give you a hint. I have 4 legs, arms and legs, and I make this sound. Yes, the wolf. Yes, excellent. Okay, the Wolff-Parkinson White pattern. If you have a Wolff-Parkinson patient, you have to do an imaging if you're looking to rule out coronary artery disease on them. And then finally, let's see. Oh, this has been a very entertaining lecture, and you guys have done a great job, so I think it's time for... what am I doing now? Resting. Very good. So resting, ECG changes. So if your ECG at rest, when you do your ECG on that person, already has ST depression on it, then the exercise treadmill is going to be useless, because remember, we're looking for on the exercise treadmill, a positive test is where normal and then depression with exercise and chest pain. So if they've already got the ST depression, then we can't do that test. Okay, so those are the 4 classic. There are a couple of relative indications as well, but those are the 4 ones just to know you need to do an imaging test. So we can do myocardial perfusion imaging, also known as nuclear stress test. And in that case, the stress is either treadmill or dobutamine and atropine. And we are looking, so that's stress number 1. In other words, we can get the heart working harder, pumping harder, faster, or we can do what's called regional hypoperfusion, which is where we actually give them these agents. They're very powerful coronary vasodilators. So normal artery will pop open and get good blood flow. Artery that has a stenosis can't change, so its blood flow doesn't change. And so what we'll see is at rest, oftentimes there's enough blood flow getting to the different parts of the heart, but then during stress, less blood flow is getting to that through the bad artery, so that muscle is going to, suffer, and good blood flow is getting to the normal artery, and we can see that difference on the nuclear. And if you see either hypokinesis on the nuclear test, or if you see where the technetium, or whichever agent you're using, if it is not getting to a certain part, it typically will be darker, it won't be as bright. So if you see those changes between the stress and the rest, that generally will be a positive nuclear test. And the next step then should be most likely to get a cath. We can also do stress echocardiography. And in this case, what we do is we actually get the heart working harder. So we do an echo, look at the contractility, and then we speed up the heart, either treadmill or using dobutamine and atropine, get the heart working a lot harder. And what we will note on the echo is the ischemic heart will get weaker. The muscle just can't pump as well, and so it doesn't thicken as much and it doesn't come in as much. And we can see that hypokinesis on the echo. And importantly, if they have the hypokinesis to begin with, and at rest and stress, that generally means that's an infarcted area. But if it's normal at rest and at stress, it gets hypokinetic. That generally means you've got a significant lesion in the artery that is supplying that territory. Okay, question 3. A 56-year-old male patient with hypertension presents with chest pain on moderate exertion. For example, when he jogs up several flights of stairs. He's a delivery driver and walks about 2 miles a day. You rule out MI, and enzymes are all negative. So his ECG shows LVH with repolarization abnormality and 1 to 2 millimeters ST depression in the lateral leads. So this is his resting ECG. And you want to order a stress test to risk stratify him further. So the question is, based on his resting ECG, what stress test do you want to order? Do you want to order a regular exercise treadmill test, an exercise test with imaging, ST segment Holter, or cardiac MR? So what would you like to order in this case to evaluate for coronary disease? All right, yes, you guys got it. He had what on his ECG, baseline ECG? Resting, yes, resting ST depression. So that means number 1 is out. We can't do the regular exercise treadmill test because we can't see that happen. It's already there at baseline. Cardiac MR, we're not there yet for coronary artery disease, and this is not considered a screening test for coronary artery disease at this time. So the exercise test with imaging is the way to go here. Okay, now let's go over the rainbow and talk about some more sophisticated cardiology tests, including catheterization, etc. So cardiac catheterization, we also sometimes call it the left heart catheterization, because we go up and we put a little tube and put some dye on the left side, and we actually go into the aorta and find the coronary arteries and put dye in. We typically do it, one of the common cases we do it is someone coming in with a STEMI, or a heart attack. And you can see on this picture that there is a complete occlusion on the left there of the left anterior descending, which was successfully stented. So we do it for that, but we also do it for in other cases as well, which we'll talk about. And those are, if someone's on maximal medical therapy and they're still having angina that is progressing or that is just not, interfering with their daily activities, or they flunk a stress test, like they have a high-risk findings, like on that lady in the question we had earlier. Now, remember, all contraindications are relative, and mortality is pretty good. We typically quote people less than 1 in 1,000 chance of dying during the test. Morbidity, on the other hand, is, it's a little bit higher. So you do have to make sure you mention that. They can get a hematoma, hemorrhage, myocardial infarction, a CVA. It can turn into an emergency bypass, femoral artery pseudoaneurysm, arteriovenous fistula. And at that top picture, hopefully you can see this is newly minted July fellow in cardiology going in and with a catheter and nicely going both through the vein and the artery and creating a beautiful arteriovenous fistula. Arrhythmias, allergic reactions, as well as occasionally dissection, cholesterol emboli syndrome, retroperitoneal bleeding. And so in this case, the catheter has perforated the aorta. Here is normal position kidney. Here is kidney going into outer space because of this big retroperitoneal hemorrhage. And they'll often have the hemorrhage will spread into superficial layers of the skin, and you can get this, what we call the gray Turner sign. And then finally, renal dysfunction, infection, and thrombosis. And the cholesterol embolization syndrome, just think about it. We're going up that aorta, and in someone with oftentimes with vascular disease with a little wire or tube, and the inside of their aorta looks like a pizza. No, a 4-cheese pizza oftentimes. And we're going around, scraping around. I mean, it's not unexpected that some of that little cholesterol plaques and stuff are going to bump off. And so it happens. And they sometimes will get a kind of a systemic type syndrome. The key things to look for on the boards are they may say that they have red, purple, or blue toes. Livido reticularis, which is this kind of lace-like pattern you can see on this feet here. Hollenhorst plaques. So Hollenhorst was a dude, an ophthalmologist, I think, and he named this little cholesterol emboli, which you can see here in the retina. So this is a little bit of cholesterol that went up to the retina. That's a Hollenhorst plaque. Here's another plaque which went to the kidney, and they can also often get leukocytosis as well, and eosinophilia. So just be aware of this. Okay, now let's talk about cardiac CT angiography. So let's give radiology a call and see if we can get a CT today. Hello, radiology. How can we improve your image today? Dr. Star-Lord here, radiology. I got a dude in here. His name's Mr. Big Mac. He's a 350-pounder. He's came in with an exacerbation of asthma and AFib. His rate right now is about 150 per minute. Did I tell you? Something's happened to his kidneys. His creatinine's 5. Can I send him down for a cardiac CT? Why, certainly not. So remember, for a cardiac CT, we are going to be giving IV contrast. We need the person to have a steady and slow heart rate under 60 and regular. They have to lay on the machine and hold their breath, oftentimes for 15 seconds. So it's a good test, but again, you have to have the right patient. Cardiac CT is being used more and more now in emergency rooms because, as you all know, getting a stress test, especially a nuclear stress test, at 2 a.m. in the morning is not doable in most hospitals. So a lot of the hospitals now are using cardiac CT or calcium scoring on these patients that come in, especially in that intermediate group, to re-stratify them. And it's pretty good now. You can see there the sensitivity, 95 to 99% for coronary disease. So if you get someone in the middle of the night, they rule out, and they do a cardiac CTA and there's no calcium, you pretty much can be comfortable about sending that person home and having them follow up, with their PCP or their GI person. Here is an older male with atypical pain who came in, ruled out, and you can see the cardiac CT showed nicely there a proximal significant and a medium lesion, which was confirmed on coronary angiography, and he received a stent. It's also good for, CT is also good for other things, for example, masses, etc. The other option is to do what's called coronary artery calcium scoring, or CACS. The benefit of this is we don't have to give contrast. So someone with an elevated creatinine can still have a CACS scan, but we're still using radiation. So if there's any suspicion that there's pregnancy involved, it is contraindicated. Again, someone coming in with an intermediate risk, with a kind of a intermediate risk patient, not clear cut, it's reasonably good. It's not for asymptomatic patients. This is only someone who's coming in with some type of coronary presentation. The good news is, if it's zero, again, there's no calcium, you can send them home relatively safely. If any calcium, then all bets are off. You need to bring them in and do your regular rule out. And the higher the calcium, the higher the chance of disease. So especially a calcium score over 400, very high risk for coronary disease. And this is an example of an elderly person who came in, and you can see they had, in fact, calcium was detected in all arteries. They had an Agatston score of 2,111 and ended up having to go to bypass surgery. Now, cardiac magnetic resonance imaging, it's good for everything but coronary artery disease. So fantastic for congenital, fantastic for infiltrative disease, fantastic for masses. In fact, we can even tell you with pretty excellent accuracy what the tissue is, because they can do tissue typing. So, for example, here is a 66-year-old who came in with dyspnea and palpitations. The echo showed some mass, and they weren't sure, wasn't good images. They did the MR, and it showed the classic signs of a left atrial myxoma here, which was resected and proven. Very good for LV-RV mass and function. One thing, main thing to remember with the cardiac MR, we're using this special contrast agent called gadolinium, and you don't want to give it to anyone who has severe renal insufficiency. They can get this almost like a systemic sclerosis develop, and it's irreversible. So that's kind of not good, so we don't want to do that. While we were talking about myxomas, let's move on to the tumors. So the good news is here, most of them are benign. 3/4 of your cardiac tumors are going to be benign, and the commonest, of course, is the left atrial myxoma. Remember, left atrial mass, likely to be a myxoma. Papillary fibroelastomas, which are these little cheerleader-type fronds here, which you can see, and they're often on the on top of the aortic valve here, but they can be in other valves. And finally, atrial septal lipomas, which is just like little fat in the atrial septum. So they're the commonest benign. The 1 in 4 will be malignant. And remember now, right atrium and angiosarcoma. So this is the common tumor that you can see as a primary cardiac tumor. So again, these are fairly uncommon. Much more common, of course, are the secondary tumors. And just to remember which are the common ones, A, B, C, air for lung, B for breast, are the commonest cause of cardiac Mets. And they can present literally with anything. I mean, with chest pain, with dyspnea, whatever. We normally start with the regular echo. As I said, there's good news and bad news here. The good news is most of them are going to be benign. The bad news is, even though they're benign, they're not normal tissue, and so little blood clots can form on them, and they move around a lot, and they can break off and cause a stroke. So most of the time, we still have to take them out, the myxomas and the papillary fibroblastomas, for example, because we want to reduce that risk of them having a stroke. And if we can, if they refuse surgery, then you need to put them on some sort of anticoagulation, antiplatelet to reduce that risk. Let's now switch over to right heart catheterization. So this is where we put a catheter into the right side of the heart, and most of the time we're measuring pressures here. Starting at the right side here, the right atrial pressure and central venous pressure, typically it's very low, almost 0 or just over 0, 0 to 6. And this is what I call the rule of sixes. Hopefully this will help you to remember the numbers. So 0 to 6 for the right atrial pressure, central venous pressure. If it's real low, super low, think shock or hypovolemic or septic shock. If it's real high, think cardiogenic shock, cardiac tamponade, or constricted pericarditis. Then moving on to the right ventricle and the PA pressure, typically systolic 12 to 30 over 6 to 12. Then moving to the left side, the left atrial pressure typically is about 6 to 12. And importantly, the left atrial pressure is about 2 to 1 ratio with the right atrial pressure. So the pressures do normally step up when you go to the left side of the heart. The cardiac index is usually 2.4 to 4.2. Again, those are divisible by 6 liters per minute per meter squared, and then you have your normal systemic blood pressure. So let's look at a couple of cases. Here is a 22-year-old end-stage renal disease. In fact, this was the guy that I showed you the x-ray of earlier. So he came in, he is hypotense, you can see. Cardiac index is still okay, but he's got elevated pressures there in right atrium, the CVP, the right ventricle, and the left atrial, all elevated. But there's something very funky about those pressures. And hopefully you can see that. And the funky thing is that he's got diastolic pressure equalization. Hello. Do you see it? Okay, so you can see here, 18, 18, 18. You normally don't have these pressures equal, especially on different sides of the heart. When you see that, you should think of two things only: cardiac tamponade or constricted pericarditis. In other words, there is some pressure around the heart which is causing the diastolic pressure to stay the same and elevated throughout the heart. And this is classic cardiac tamponade in this case, because we know he didn't do dialysis, so he got fluid built up around the heart. This case is a 66-year-old man with hypertension, diabetes, and cholesterol with severe chest pain for 4 hours, diaphoresis, nausea, vomiting, and lightheadedness. So let's take a look. Okay, he's got bad, low blood pressure, 70 over 50. Cardiac index, abnormally low. His pressures are elevated, but he does still maintain the 2 to 1 ratio, and it's not diastolic pressure equalization, so we know it's not tamponade or constricted pericarditis. But with the story and the risk factors, he is in fact having a big heart attack, and he's got biventricular failure with cardiogenic shock. You can see the classic, he's got the classic numbers, a cardiac index less than 2.2 and a wedge over 15. These are consistent with cardiogenic shock. Okay, now let's talk about the physical exam. And, sometimes you guys will get to the physical exam questions on the boards and it'll be like Panic at the Disco. But I'm telling you, you can be victorious if you know a couple of key pieces of information. So firstly, the physiologically split S2. So this is normal. So if you take a deep breath in and there's more blood on the right side, the right ventricle, remember the P2 is made up of A2 and P2. A2 comes first normally, and then P2 comes second. So if there is more blood during inspiration on the right side and less blood on the left side, what that means is that A2, the closure of the aortic valve, is going to happen earlier because there's not as much blood on the left side, and P2, which is the closure of the pulmonary valve on the right side, is going to happen a little bit later because there's more blood to come out of the pulmonary valve. So this is normal. Have a listen to yourself later if you or when you get back. Normally, you should hear lub-dub, lub-dub, and if you take a deep breath in and hold it, you should hear lub-dub, and then breathe out lub-dub, lub-dub. So that's normal. What is not normal is if you hear lub-dub, lub-dub the whole time, and when you take a deep breath in, it does also get wider. Lub-dub, lub-dub, and then breathe out lub-dub, lub-dub. That's what we call a widely split S2. So it's split the whole time, but it still varies physiologically. And this can be seen either early closure of the aortic valve for some reason. For example, someone with severe mitral regurgitation. Less blood is going to come out over the aortic valve, more is going to go backwards over the mitral valve, so the aortic valve is going to close earlier. Or if you've got someone who has pulmonary stenosis or some other pulmonary high pressure, so that it's going to be harder for the blood to be pumped out on the right side and for the pulmonary valve to close, so it's going to be delayed. So let's have a question on this. Physical exam. A 43-year-old woman reports dyspnea for 6 months. Echo shows severe mitral regurgitation and pulmonary hypertension. So what would you expect to hear on auscultation of her second heart sound? A normally split, a widely split, a paradoxically split, or a fixed split second heart sound. So severe MR, pulmonary hypertension, what do you think you would hear on her heart sounds? Excellent. You guys are on it, so she should have a widely split second heart sound. Now, she wouldn't have a paradoxically split second heart sound. Paradoxically split means that everything's backward. So your aortic valve, instead of being aorta first and pulmonary second, it's the other way around. Pulmonary first and aortic second. We typically see that with a left monobranch block, which she didn't have. And fixed split is a special type of split where it doesn't vary, the timing does not vary with respiration, and here is the main cause of a fixed split S2. So just think fast as a flash. So fast, fixed split, AS for ASD 2. So fixed split, ASD, second heart sound. This is the commonest cause of a fixed split S2, ASD. And you can find other things that can help you to nail down ASD. Some of those other things include sometimes you'll hear a pulmonary flow murmur in those individuals. Also their ECG with the commonest type of atrial septal defect, which is ostium secundum, often shows a right bundle branch block or incomplete right bundle branch block and right axis deviation. So they're classic. And generally we will fix these if they have a big shunt, so greater than 2-to-1 shunt, or symptoms, or if they have a big RV without signs of pulmonary arterial hypertension. We will generally close them. Okay, next question. An 18-year-old female from Honduras says that she has had a murmur since birth, and she was told by her doctor that she had a hole in the heart. You detect a split second heart sound that does not vary with respiration. There is a 3/6 systolic flow murmur in the pulmonary area, and the ECG shows right axis deviation and a right monobranch block. So what do you think is going on here with this lady? Is it mitral stenosis, aortic coarctation, an atrial septal defect, mitral regurg, or hypertrophic cardiomyopathy? So she's got a split second heart sound that does not vary with respiration, and she's got some changes on the ECG. What do you think is the diagnosis here? Wow, 99%. We are almost there, guys and girls. We are 1% away. Okay, so fixed splitting of a second heart sound you would not see with mitral stenosis. You would also see other signs with mitral stenosis, which we'll be talking about later, including a diastolic opening snap and a rumble, which she does not have. Now, her doc, believe the docs. I mean, have some skepticism, but, often in the, particularly where they don't have a lot of imaging, they are pretty good with their physical exam. And he told her that she had a whole heart. He was right. She does have a hole, and that particular hole is an atrial septal defect. Okay, let's talk about the S3. S3 is an early diastolic sound. So you hear lup-da-da, lup-da-da, lup-da-da. It's the sudden termination of early rapid filling into a stiff, dysfunctional ventricle, or it may be related to the tensing of the chordae, kind of like a bass guitar, brum, brum. So this is S3. So the left-sided one is the one we're most often interested in. You can hear it when they're at the apex with the bell. Remember, you want to use the bell. And remember, you want to do it, watch their breathing when the breathing goes down. So, when they're expiring, expiration. When they're expiration, that's when you will hear the left side because there's more blood on the left side during expiration. So this is when you'll hear it. The classic ones that you will hear it in are heart failure, reduced ejection fraction, as well as these high flow states like AR, TR, MR, VSD, ASD, and PDA. You can also hear it physiologically. So just looking out in the audience, it looks like most of you all are under 40. I could hear it physiologically in you, or if you were pregnant as well, and there's some other causes there. Valsalva. So sometimes the boards will say, give you a person with a murmur, and they'll say, as a board-certified internist who is very excellent at physical exam, you perform a Valsalva maneuver, and you notice that the murmur increases during the strain phase of the Valsalva. What is going on? And so remember, murmurs that get louder during the strain phase of the Valsalva include mitral valve prolapse and hypertrophic cardiomyopathy. They're the two classic ones that will get much louder during the strain phase of the Valsalva. And Valsalva is one mechanism to do it. You can also do it with nitrates or standing. Essentially what they do is they reduce preload, and that reduces LV volume, and that increases the amount of obstruction in these particular cases. And hand grip, murmurs that will be louder with hand grip include, my little mnemonic here, MAV's hand grip is loud. So M for mitral regurg, mitral valve prolapse, A for aortic regurgitation, V for VSD are loud. So with the hand grip, they will be louder. And the reason for that is the hand grip increases the cardiac output and peripheral resistance, which will increase the flow across these murmurs, across these particular vessels and lesions, and this will increase the loudness of the murmur. Elevated jugular venous pressure. Remember, we're talking about the internal jugular vein here, but in all honesty, most of the time, if they have elevated pressures, the external and the internal are going to be up. And just remember, other than heart failure, which is the commonest thing, there is a differential for elevated jugular venous pressure, which is given there. Canon A waves. So these are these huge, big bumps that you see in the neck. And these Canon A waves indicate AV dissociation. In other words, what's happening at the exact time you see a Canon A wave is that the right atrium and the right ventricle are both contracting at the same time. Of course, the right ventricle always wins. It's stronger, bigger muscle. So no blood goes across the tricuspid valve. It stays closed. And instead, when the right atrium contracts, the blood goes up superior and down the inferior vena cava, and you see these huge, big, what are called A waves. And so you see these classically with ventricular tachycardia, with third-degree AV block, and with ventricular pacing. Now, finally, let's talk about pulsus paradoxus. So everyone have a quick feel of your pulse there. Remember, underneath your thumb, and use your fingers, not your thumb. You'll get a good reading. So everyone's feeling your pulse now. Now, what I want you to do is take a deep breath in and hold it. And about now, you should feel your pulse getting a little bit faster and a little bit weaker. Remember, you've got more blood on the right side, less on the left. And then breathe out. And hopefully your nice, strong pulse return to normal. So there is a normal amount of drop in pressure when you take a breathe in. There's a little bit of variation, typically, 2-3 millimeters, not 10 millimeters. If it's 10 millimeters, in other words, an inspiratory fall in systolic blood pressure of 10 millimeters or more, this is what we call pulsus paradoxus. And my little mnemonic to help you here is the car driving cat. So cardiac tamponade, constricted pericarditis, asthma, and tension pneumothorax. Those are the commonest causes of pulsus paradoxus. So question 6. Moments after a temporary transvenous pacemaker was placed into the right ventricle of a 50-year-old male with complete heart block, he developed hypotension, chest pain, and elevated neck veins. Heart sounds become muffled, but lung fields are clear. You note an inspiratory fall in systolic blood pressure of 15 millimeters mercury. So what do you think the echo will show? An ASD, acute mitral regurg, hypertrophic cardiomyopathy, and cardiac tamponade. Remember, you've just stuffed this hard wire into the right ventricle, jamming a pacemaker in, and all of a sudden he's become hypertense and he's got maybe pulsus paradoxus. What do you think might be going on here? Right on. Okay, so cardiac tamponade, yes. He's got all the signs of cardiac tamponade. The heart sounds muffled. He does not have hypertrophic cardiomyopathy. that would show different things on the in the neck veins, etc., and also physical exam. He also does not have an atrial septal defect. There's no mention of a fixed split S2 or pulmonary flow murmurs. Okay, good. Okay, we're going to get started with lecture 2. This lecture we're going to be talking about acute coronary syndromes. This is kind of like the person presenting with the acute coronary syndrome, a common thing that you will be asked about on boards. As well, we're going to talk about the stable ischemic heart disease and hyperlipidemia. So the acute coronary syndrome, I think you're fairly familiar with that. We've got someone who has developed a plaque. You can see there in the top diagram, you've got plaque developing, and then you've got in the lower diagram plaque rupture, and they get either partial or complete occlusion, which causes the supply-demand imbalance and their chest pain. So what are some of the signs and symptoms of acute coronary syndrome? I think you guys and girls are familiar with the common ones. Be aware that elderly diabetics and women can present with funky symptoms, including just shortness of breath or dyspnea, heart failure, confusion, fatigue, and nausea. So take those seriously. Also, important to know the quote-unquote new risk factors that have been added to the risk factors that probably you're aware of. So now these are official coronary artery disease risk factors. Preeclampsia, pregnancy-induced hypertension, gestational diabetes, systemic autoimmune collagen vascular disease, especially lupus or rheumatoid, double the risk. HIV, double the risk. Chronic kidney disease as well. So be aware those are risk factors and you need to ask about them now. So what do you want to do when they first hit the ED? In that first 10 minutes, you want to get them to chew on this, give them an aspirin, stick them, get the ECG, chat them up, so find out a little bit about the history and the physical exam, stick them and get that troponin drawn, and then finally, take a look at them and find out how hot they are. So here is the spectrum of acute coronary syndromes. You can see presentation, they come in, and then you do the ECG, and then you can divide them up pretty quickly into the non-ST elevation, because they don't have ST elevation, or the ST elevation. And then, based on the enzymes, we can give them their final diagnosis of either unstable angina, non-STEMI in the case of the non-ST, and then STEMI, of course, in the case of the ST elevations. So what do the ECGs look like for these? So for the non-ST segment elevation acute coronary syndromes, the classic findings that we get are ST depression or T-wave inversion, or both. And you can see that oftentimes, when they're treated, they will, and the chest pain's gone away, they will resolve and go back to normal. So here is a classic non-ST elevation acute coronary syndrome. This was a 60-year-old African-American with chest pain, and I'm hoping you can see on that ECG that nice ST depression that person has with their chest pain when they presented, as well as some T-wave inversion. In contrast, ST segment elevation myocardial infarction, it is called that because us dumb cardiologists, forget things. But now we say, oh, ST elevation. So ST elevation is what they're going to have. Before they get the ST elevation, however, in the first 15 minutes, the first thing that goes up are the T waves. They get these tall, peaked T waves. Then, in about 15 to 30 minutes, the ST segments start coming up. And then in about, 30 minutes to an hour, the QRS, the R wave, starts to get smaller, and actually they can Q out in as little as 2 hours into their infarction. And then weeks later, they will hopefully get resolution of that ST segment. Sometimes they are left with a residual Q wave. And you can see here, if they have a new left bundle. Okay, so, the new guidelines do, in the old guidelines that you guys probably are aware of, we used to say STEMI or new left bundle branch equals the same as STEMI. The new guidelines have said no, because what they found was they were cathing a lot of people with left bundle branch blocks, and more than 50% of them had no coronary disease. So they've kind of fine-tuned that in the new guidelines. And so what they're saying now is if you've got a new left bundle branch block and they're hemodynamically unstable or have heart failure, that is called a STEMI equivalent. Or if they have a old left bundle branch block and they have the Scarabosa criteria, that's also called a STEMI equivalent. So when they use those criteria, much more of the people did have true STEMIs. So that's the new definition for STEMI with left bundle. And we know that depending on where the ST elevation is, that can help us determine what artery is involved. And so you can see there, for example, with leads V5, V6, 1 and AVL, that is a lateral STEMI, and that's typically with the left circumflex artery. Remember, circum around, flexo bend, so it's the artery that goes around the heart on that left side. So here are some examples. This is a 68-year-old Caucasian male with severe chest pain. And he actually came in with ST elevation